to everybody. It's 7 o'clock on Monday evening, and we're going to review for our exam. But as Terry so graciously pointed out to me, I never finished the pulmonary stuff. So we're just going to go over asthma, restrictive obstructive disease, and we'll be reviewing for that as we move through here. Pneumoconiosis, lung cancer, pneumonia, PE. So, and then ARDS, which y'all are never going to see, hardly, I can't imagine, in a non-ICU setting. So, asthma is very common. You'll see that a lot in your primary care settings. Asthma is a chronic disease, and some authors put it under obstructive, but asthma is usually caused by some trigger, and those triggers cause inflammation. So you can have asthma that's well controlled, and then you can have acute asthma on top of your chronic asthma. The thing about an asthma exacerbation is that it has both a early and a late response. So what happens is that a trigger starts with the inflammatory mediators, and that trigger can be pollen, it can be a cat pollen, it can be dog, it can be mold is up right now, ragweed, just a myriad of things. Somebody's cologne, somebody's aftershave. And it starts the inflammatory process, and there's a release of histamine, prostaglandins, and leukotrienes. Now, in the early stages of acute on chronic asthma, the bronchial mucus or mucosa activates those mediators that I mentioned and causes vasodilatation. So when you get that vasodilatation, then you get this inflammation of the wall of the airway, and it becomes thickened. Okay, the smooth muscle here is still relaxed, but you've got this inflammation here. And that causes bronchial spasms and contributes to the assessment sign of having wheezing. Now, people with asthma have more goblet cells, and goblet cells produce what? Mucus, exactly. So now you've narrowed your airway internally, and you have excessive mucus production. So that leads to some obstruction in those airways, and it leads to wheezing. And if you notice on the bottom right here, we have a peak flow meter that patients should be using on a daily basis to see where they are and how much obstruction they have. Now, the second phase, or the late phase attack, is as much as 8 hours later. So they go to the emergency room, they give them a bronchodilator, they're doing okay, they go home, and about 8 to 10 hours, because they've already given them a bronchodilator, they start developing hypoxemia, they hyperventilate, they have a drop in their carbon dioxide levels and an increase in their pH. Okay, so if I blow off my carbon dioxide level and my pH increases, I get respiratory alkalosis. I'm still producing excess mucus. I still have inflammation and narrowing of the inner lumen, but now the respiratory muscles begin to tighten, that smooth muscle contraction. So not only do you have narrowing caused by inflammation of the mucosa, you have obstruction because of the mucus, and now we're going to tighten down on those airway muscles that wrap around each of the airways. So the patient can't take a big breath, and what air they do get in, they start having trouble getting back out. And with that, they begin to fall into respiratory acidosis. And that is the point of respiratory failure, and for that you get intubated and put on a ventilator because they can't get it reversed. Because it's difficult to reverse that. The reason being is that most people with asthma have their own bronchodilator, which is their albuterol inhaler, and they suck that thing dry when they're having an exacerbation. Well, there are only so many binding sites in the lung, and once they have all been filled with albuterol or whatever other kind of bronchodilator the patient has, then it becomes very, very, very difficult to continue to bronchodilate because there's no place for the medicine to attach to. Now, you can also have some problems with left ventricular filling when you start to have this respiratory acidosis, and you have all this hyperinflation. So in my practice, I generally don't get chest x-rays of people with acute exacerbation of asthma because all I see is a hyperinflated chest film. If I think there is something else going on, like comorbid pneumonia or maybe a dropped lung or some other things, then I'll get a chest x-ray. But you basically are going to have a hyperinflated chest x-ray, and that's what you're going to see, hyperinflated chest x-ray. Any questions about asthma? Okay. Oops. No, ma'am. You're so kind. All right, let's talk about chronic bronchitis and COPD. Did I go too many? Oops. No, I didn't. Okay. Now, chronic bronchitis, you have to have 3 months of the year, usually during the winter months, whenever that may be for where they're living, a productive cough with mucus. It has to be hypermucus secretion for 2 years, and then we'll tag you with, oh, they have chronic bronchitis. So over the years, the airways become continually inflamed, and that can be caused by smoking, a lot of reasons, smoking being number one, or kind of work that you inhale things that you weren't meant to inhale. So this chronic inflammation causes, again, the edema of the internal airways. It destroys the mucociliary escalator, and when that gets destroyed, it's replaced with columnar epithelial cells, and you get more mucus glands and more goblet cells that are produced. Now, the mucus that's produced in chronic bronchitis is usually fairly thick and tenacious. And in that mucus, you cannot get it cleared. One of the reasons is because your mucociliary escalator, which used to be, had steps, now has spots that are bald, if you will. So those little cilia that you see here, they have an area that there's nothing. And so it gets so far, and the stuff, the mucus and the stuff that gets trapped cannot jump to the next step. So you have trapping of air, trapping of mucus. to upper respiratory and lower respiratory tract infections. Those continued infections continue to destroy the mucociliary escalator. And so it's just, once it starts, it's self-perpetuating. Now, if you get somebody to stop smoking, then you can have some repair of that mucociliary escalator. The old cell type, the ciliated epithelium will come back. But these people are particularly prone to streptococcus pneumonia and Haemophilus influenza. So it's important that they get their pneumonia vaccines, Pneumovax, and the new pneumonia vaccine, because it's different strains. And then that they always get an annual flu vaccine. Now, a long time ago, long before any of you were probably ever nurses, way back in the 70s, some clever person wrote an article called The Blue Bloater and the Pink Puffer. And those are all well-dated terms, but the people with chronic bronchitis were labeled blue bloaters. And the reason is that they tend to be, as this gentleman is, a little bit obese. They don't do much because they're breathless. And they tend to be slightly dusky appearing because they have hypercapnia. And they don't breathe as deep, so they have chronic hypoventilation. Now, one of the things that we used to always say is these people belong to the 50-50 gas club. Their PO2 here is 58, which absolutely requires supplemental oxygen. And their PCO2 is over 50 because of their CO2 retention. But the myth that these people should never be given oxygen is just that, it's a myth. If your PO2 is 58, please put oxygen on that patient. You have to be ready to intubate them should they decide to stop breathing. But their normal mechanism for a high CO2 as a drive to breathe has been blunted. And so it's their oxygen level that triggers their breathing. But if you give them the right amount of oxygen and you can provide support, don't let them sit there with a PO2 of 58. Now, the brother to chronic bronchitis is emphysema. Emphysema can be caused by smoking. It can be caused by alpha-1 antitrypsin disease. People who get and develop emphysema in their 20s most likely have alpha-1 antitrypsin disease. They don't have the right chemical or the right mediator in their lungs, and those people end up needing lung transplants. So the difference between in emphysema is that you have a breakdown of those supportive walls that maintain the alveoli. So all those little supportive walls in here begin to disintegrate and crumble. So you have over 300 million alveoli in your body, enough to spread it out over a full tennis court. And so initially you may not, or the patient may not notice some of this damage that's occurring. And they will say, you know, I was doing really great until we went on vacation and then I couldn't breathe anymore. And it's because they got down to that critical mass of alveoli that needed to be there. So you lose the elastic recall and it becomes difficult to exhale. So you get air trapping here, and these patients develop a barrel chest. But they tend to be thin because their work of breathing is so high that they are burning up calories at a fabulous rate. This is totally irreversible. Like you can reverse the bronchospasm and the bronchoconstriction in asthma, you cannot in people with emphysema. So they have a loss of the normal mechanics of the respiratory muscles, and they get this barrow chest, and they usually have thin arms and legs. Okay. So if you look at chronic bronchitis versus emphysema, some key characteristics are, you don't necessarily have you don't have a productive cough in emphysema except when somebody has an acute exacerbation. They are short of breath, more often early on in emphysema. Most of them have a smoking history, except those who have alpha antitrypsin deficiency. Classic barrel chest and emphysema, prolonged exhalation, very common, gives you the blue bloater picture. The bronchitics have the hypoventilation, and they get polycythemia. Why do you think they get polycythemia? Why do we see polycythemia in patients with chronic bronchitis? Y'all weren't ready for a question, were you? Let's see what Jen has. No, it's not the erythropoietin. Yes, very good, Teresa. They have low O2. And so the primary carrier of oxygen is the red cells. So you get more red cells in an effort. You take them way more complicated. No, you just need more red cells in an attempt to try and carry more oxygen. Now, this is an excellent example of overthinking the question. Okay? Don't overthink the question. Just, why are they polycythemic? Because they need more red cells to carry oxygen because they're hypoxemic. Okie dokie. Okay, pneumoconiosis is the umbrella name for everything such as silicosis, asbestosis, black lung. They're all fibrotic lung diseases, and it's all from inhaling stuff you're not supposed to. So here's healthy lung tissue. Here's 90-year-old school teacher with healthy lung tissue. And the biggest change is, they probably don't breathe as deeply anymore. But this is what asbestosis is particularly, is an example of a coal miner in the black part of the lung, why they call it black lung. The thing to remember is it's not reversible. There is nothing we can do. We can't treat it. We can provide palliative care and reduce exposure, but we cannot reverse it. So this is not a good diagnosis to get. Oh, you have pneumoconiosis. Yes, it's asbestosis. It depends on how old they are. These people generally don't start having symptoms until later in life when they no longer are lung transplant candidates because they have other comorbid mortalities, and so they won't operate on them. Asbestosis, besides being, from when we did asbestos everywhere, the other really prevalent job was mechanics, because we had asbestos in the brakes. And so they can have asbestosis. But, they're going to be 50, 60 years old before they have that kind of presentation. And we don't usually transplant people that old unless they have large quantities of money. I never said that. I never, ever said that. Okay, lung cancer. Lung cancer is pretty prevalent. Of course, course, all lung cancer is not associated with smoking, although any long-term kind of inflammation can lead to cancers. Non-small cell presents with central, which is like in the hilum, and the hilar in the middle, problems. So you get a chest x-ray, and they have hilar tumors. Those tumors then project into the bronchus. Don't often present with chest pain until it's late. And these non-small cell don't metastasize. Maybe late in the disease course, but not early on. They tend to be fairly well localized. Small cell lung cancer is the diagnosis you really don't want to have. Most patients die within 12 months of getting a diagnosis of small lung cell cancer. They often present with hemoptysis. Here lately I've been coughing up blood, and I think of two things. What do you want to think of if somebody comes to your clinic and says, I've been coughing up blood? What are the first two things for your differential? Tuberculosis, and then the second thing you think of is lung. So you go, it could be TB, but it probably is lung cancer. Because if they don't have the night sweats and the weight loss, although in cancer they could experience I was seeing patients for one of my colleagues. He was on leave, and I was seeing his patients while he was gone, and this guy came in his late 50s, non-smoker, coughing up blood, no weight loss, no symptoms of TB. We did a TB skin test. That was negative. I sent him for a chest x-ray, because you always send hemoptysis for a chest x-ray. He had lung cell cancer, and he was dead in 4 months. So it's a very, very aggressive disease. They go far and wide, and it has the worst prognosis. So if you're going to get lung cancer, do the non-small cell. Don't pick the small cell. Okay, pneumonia. You're going to see this all the time. And number one pneumonia is aspiration pneumonia. So people, when they sleep, you aspirate a little bit, but some people aspirate more. And especially in the elderly, where they don't have the same cough reflex or any of that, so they inhale organisms. They're really not good at coughing and sneezing, and they get a lower respiratory tract infection. One thing you have to be sure is that they take care of their respiratory therapy equipment. Now, I'm not in favor of the magic CPAP cleaning machine, but they need to clean out the nebulizers. They need to clean the tubing. They need to replace the tubing on a regular basis, especially if they put water in for humidity, because that'll just grow all sorts of stuff, and then you can just aerosolize it to the depths of the lungs. So patients present with often fever, dyspnea, chills, cough, pleuritic chest pain. And on exam, you may hear crackles. Never use the word rouse. We stopped using rouse in 1974. There's a paper by the American Thoracic Society. It's crackles. So that's just my big bias here. We need not to be using that because it shows that you're old. So you're looking for crackles. They don't always have to be inspiratory. They could be both inspiratory and expiratory. You want to assess, and you'll learn this next semester because you're all passing this class, I'm sure. You get tactile fremitus, egophony, and whispered pectoriloquy. And if they have some underlying disease like diabetes or heart failure, you may see an exacerbation of that. People with infections who also have diabetes show a spike in their blood sugars, and it's secondary to the infection. Now, if everybody got their Pneumovax and then the second vaccine, we wouldn't be having this problem. Now, a very important thing that you may see as somebody coming into your clinic who says, oh my God, I'm short of breath, I can't breathe, is the development of a pulmonary emboli. And a pulmonary emboli is alveolar dead space, because there's no blood flow past the alveoli. So if the blood doesn't flow by, it can't exchange oxygen. So if there's no oxygen exchange, then you have a mismatch in the ventilation and perfusion. We don't do ventilation perfusion scans anymore because they were always indeterminate and didn't give us a lot of information. When you increase that alveolar dead space, you also decrease production of surfactant. And surfactant is what keeps those little alveoli, causes surface tension, and then they stay open. Now for pulmonary emboli, we do spiral CTs. That's the standard. So, you get some widespread vasoconstriction because of the emboli, and that impedes blood flow as well. We give low molecular weight heparin, and then we try to figure out where that emboli came from. So, did they have a DVT? Did they get a blood clot somewhere else? So we look for that. Like, did they have a fracture, and that's caused it. We also measure the serum D-dimer level. And what does the serum D-dimer level represent? Degradation of thrombus. Exactly. Okie dokie. I don't anticipate us having any problems with the video, but the Great Rains have just arrived in St. Louis again. Okay, so you want to get, look for risk factors, check out and see, get the spiral CT, and try and figure out where that PE came from. PE is a singular cause of death in patients in the hospital because of immobility and things like that. The spiral CT, it's a CAT scan, but the way the CAT scan goes around the person, it totally no, we don't do an angio. You don't have to. You don't want to put them at risk for die. But the spiral CT then looks 360 degrees around the chest so that you can get a total picture of what's going on. Okay. All right. One last thing to talk about before we go back for the full review is ARDS, Adult Respiratory Distress Syndrome. And ARDS was first, I don't want to say discovered, but during the Vietnam War, when guys would be given large volumes of fluids coming in from the fields back to the MASH tents. And they had severe pulmonary edema. It changed the way their lungs worked, and you had flooding of the alveoli with the pulmonary edema that turned off the surfactant. They were dyspneic and became hypoxemic, even in the face of having supplemental O2. They hyperventilated, they got respiratory alkalosis, but they could not maintain oxygenation. And in these are the people that you see on levels of PEEP. Okay, they're on high levels of PEEP, and so you're really trying to get them to ventilate. And the reason you put them in a prone position, Dina, I know, but tell everybody else. You shift the fluid, exactly. So if you're supine in a prone position, then you've got all of the surface area where blood will go to, because you know it's going to follow gravity, and you're going to have a greater mass of alveoli that you can use. If I sit you up, it's just the lower lobes. If I put you on your head, it's just the upper lobes. So we put you on your back, and as Dina says, there's a rotoprobe bed that helps with this. And it's a nursing technique that we use, you know, with pneumonia and those kinds of things. What are you trying to do? And in this case, we're trying to improve oxygenation, so we want to have maximum number of alveoli that interact with the blood flow. So this hopefully will help decrease the work of breathing. We add PEEP to the ventilators, so we have some positive end expiratory pressure that will help keep alveoli open and increase the oxygenation. What we don't want to happen is that they run this whole gamut where the work of breathing increases, they become hypoventilated, they have hypercapnia, respiratory acidosis, their cardiac output falls, and then they die. And back in the 70s, that's usually what happened. If somebody had ARDS, it was like 90% of the time they died. It still has a very high mortality, but not like it did back then. Okay. All right, so now that's all the lung stuff that I failed to do before. So let's kind of go through, and I'll ask you some questions and see. We'll get rid of this. Well, I know, I'll let you use the slides if that helps. Okay. All right. So, let's talk about the renal system. What's the most common renal stone? Absolutely. How much of a reduction in the cardiac output needs to take place to let the kidneys know that there's a problem? And so they can, not 50%, 20 to 25%. And what does that trigger then? What will it activate? I reduce the cardiac, the RAS system. Excellent. All right. Urinary tract infections are common in women, but in men, what is the usual cause of the urinary tract infection? Prostatitis, exactly. Define polynephritis. Doesn't have to be urinary obstruction, but what happens in polynephritis? You may have some reflux of urine, but what areas of the renal system are infected? Upper tract, exactly. The kidneys, the ureter, exactly. The renal pelvis. Those are the things that get infected. And the cause could be an obstruction or a reflux of urine from the bladder. What are the most common organisms that cause pyelonephritis? E. coli. What else? Proteus and Pseudomonas. Excellent. Okay. Now, sometimes we have disorders that affect the glomerular filtration rate. What's a normal glomerular filtration rate? A normal GFR. Ooh, good job. That was like all at once. 15 is too low. 15 to 60 means you have kidney disease. 60 or greater is normal. Excellent. Okay. All right. What about acute kidney disease? How do we define acute kidney disease? Progressive. It can happen in hours. It's very rapid. It may be reversible, so remember that stuff. It can be acute on chronic, so somebody could have a chronic end-stage renal failure and then develop an acute renal failure, acute on chronic renal failure. How much loss of glomerular filtration do we need to see changes in the serum creatinine level? 50%, exactly. Okay. And what fluid and electrolyte abnormalities can you expect in these people? Hyperkalemia. Okay. All of those things are possible, but the big things are hyperkalemia, metabolic acidosis, and fluid retention. Again, just keep it basic. Don't try and overthink the question. Okay, what do we think is one of the primary causes of GERD? H. pylori. Yes. So, what can cause the lower esophageal sphincter pressure to become very low? The things you want to tell your people not to, the things to avoid. Not medications. They got to take medication. 4 very happy things. Caffeine, nicotine, which would be smoking, and alcohol. So caffeine, alcohol, chocolate, and nicotine. Those are the things. Lying down after eating would make them at an increased risk, but the caffeine, alcohol, chocolate, and smoking, nicotine, are the most, the foods that lower esophageal sphincter pressure. Spicy foods don't lower that lower esophageal sphincter. It doesn't change the pressure. It's just if they have other things and they're eating spicy food, they could have reflux. And that they say, oh, I can't eat spicy food, is because they reflux and it burns because you have all this unprotected mucosa here, and you're going to add habanero peppers to it, and that will make things really hard. Okay, bowel obstructions. What's the #1 cause of bowel obstructions? cause some bowel obstruction, or it could be twisted around. The bowel could be twisted around, but the number one cause are these little things here known as adhesions from having other surgeries. If that stays a long time, you may actually kill the bowel. And why do adhesions occur? They're like a scar. It has nothing to do with their diet. It's just they've been in here cutting around, and so the body creates these scars, and they're called adhesions, and because they adhere to different parts of where the surgery took place. But it has nothing to do with their diet. It's just like a scar forms after you've had surgery. It's just your body's response to being violated. Doesn't like to be cut and twisted and turned. Okay, oops, wrong one. All right, and that's here's the peptic ulcer disease, which contributes highly to GERD. That's one of the big things. There's your little H. pylori. It's a disgusting little thing. But chronic use of NSAIDs causes a decrease in bicarbonate secretion and mucin, and those things are there to protect the gut. So if we have this little H. pylori devil in here, and we use a lot of NSAIDs, we drink, we smoke, we have COPD, we're obese, we have psychological stress and cirrhosis, then you develop peptic ulcer disease. And it usually occurs in the duodenal area or in the gastric area. And then if we continue to dump coffee and all those things in there, we lower the esophageal sphincter pressure, and we reflux things up into the esophagus. But those little H. pylori devils cause a lot of problems and contribute to your GERD. Okay, dumping syndrome. Dumping syndrome happens a lot because of why? Gastric surgery, bariatric surgery is one cause. Sometimes you can just do it by what you're eating, but you have rapid gastric emptying, and there's a high osmotic gradient, so water is pulled into the bowel and then zoomed. Not so much, people with diabetes, depending on what they're eating, but you can get dumping syndrome if you overdo on Thanksgiving and you're doing all those pies and all those things. Not a cholecystectomy generally doesn't lead to dumping syndrome unless they're doing something else. So it's primarily a pyloroplasty or gastrectomy is where we see these most often. And how do you manage this? Diet. Exactly. Easy, slow. You mean eat slow? Just messing with ya. You're not supposed to drink when you're eating. You're supposed to eat small meals, high protein, low carbs. Poor carbs, they're the best thing in the world, but bad rap. Okay, Crohn's disease versus ulcerative colitis. What kind of lesions do we see in Crohn's disease? Skip lesions, exactly. And where is ulcerative colitis is primarily located in what? The colon and the rectum. And Crohn's disease goes where? All over, the entire GI tract, mouth to the anus. Exactly. In Crohn's disease, the entire intestinal wall is involved, and in ulcerative colitis, it's the mucosal layer. Let's see here. what symptoms would lead you to believe the patient who's coming in with abdominal pain has ulcerative colitis? What kind of symptoms? Nausea, one. Bloody diarrhea, yes, yes, yes. Okay. And in people with Crohn's disease, because that was ulcerative colitis, what do we have? Abdominal pain, diarrhea, small intestinal malabsorption. Very good. Okay, what is one of the main functions of the liver? It detoxifies, it synthesizes amino acids. Okay, good. Now you have carbohydrates or amino acids that are converted to carbohydrates by a removal of ammonia. Where does the deamination take place, and what is the ammonia changed to? It gets changed to urea. So the liver is responsible for converting the hepatocytes within the liver, responsible for converting the carbohydrates to ammonia, and then deaminate it so it gets excreted, converted to urea and excreted through the kidneys. Okay, cirrhosis of the liver is reversible or irreversible? It's an irreversible, inflammatory, fibrotic disease. And what are the two most common causes? Alcohol abuse and viral hepatitis. Okay. Now, portal hypotension results in, or is caused by, what's the most common cause? Right, esophageal varices. So when somebody has esophageal varices, then you think portal hypertension. And that congested spleen causes what? Your spleen becomes congested, thrombocytopenia, okay, and it can contribute to bleeding tendencies. Okay, in hepatic encephalopathy, what part does the liver play in hepatic encephalopathy? The liver can no longer, the blood is shunted around the liver, and that prevents the liver from doing its work. So neurotoxins and other substances absorbed from the GI tract then move freely into the brain. Ammonia is the worst offender because ammonia cannot be converted to urea and excreted. Okay, acute pancreatitis. patient presents to your clinic with upper gastric or mid-abdominal pain. Their pain radiates to their back. They have fever and leukocytosis, and they have a history of chronic alcohol abuse. Your diagnosis? One of the things on your differential is acute pancreatitis. And so if they have electrolyte imbalances such as hypocalcemia, or they have tachypnea or hypoxemia, then they're developing complications of their acute pancreatitis. Why is there hypocalcemia and acute pancreatitis? Okay, let's think this through. Okay, who produces calcium? Where does the calcium come from? Okay, the parathyroid stimulates the production of calcium. So now we have a disruption of this because this is a critical thinking question. You do get some inflammation in the pancreas, yes. What would you expect more than hypocalcemia, though? If you're going to make the pancreas crazy, what other thing would you expect to happen related to the pancreas? We'll get back to hypocalcemia. Amylase and lipase, insulin, right. You get increases in things related to diabetes. Does that make sense? Yes, no? Okay. Yes, haha, smiling. I know. Oh, come on. Let me find the answer to your question here. Okie dokie, I don't care about cancer. Because my brain is not wanting to work this very minute. All right. Other questions about acute pancreatitis, so I make sure I don't tell you something wrong here. It'll pop into my brain in just a minute, but no, you don't have to know treatment. That's not for this class. That's for your classes. You just need to know what happens and why it happens. Alright, we'll just go on because I can guarantee that question's not on the test. Did you like that? I can guarantee that. Yay! They all said yes, yes, yes. Okay, let's see. All right, do we need to go over all the stuff for reproduction? Are you good with that? We should be pretty good with that. That's the last thing we did, and I think when we reviewed the other day, we had that. But, all right, what causes spermatocele? We're just going to do this. We'll tell him to put in earplugs. But what causes a spermatocele? No, it's not. It's equal. We equally distribute the test questions. Yes, it's a cyst in the epididymis. All right. If you have descent of the posterior bladder wall and trigon into the vaginal canal, it is what? What is it called? It's called a cystocele, yes. If you think somebody's been exposed to gonorrhea, what else do you need to test for? Chlamydia, because they come as a package. Okay. What is the chemical mediator associated with dysmenorrhea? Prostaglandin. Excellent, excellent. What virus is associated with cervical cancer? HPV. Excellent. Yeah, I think that there's not that many questions on each of these. They're just... Okay. All right. Polycystic ovarian disease. Know what causes that? Or what's associated with polycystic ovarian disease? Genetic basis is suspected, cause is unknown. But it's a hyperandrogenic state. That's important to know. Okay. Obesity worsens. Benign ovarian cysts, you make those every month, and they are benign. Now we don't call anything sexually transmitted diseases. They're sexually transmitted infections. Let's see here. We talked about prostatitis. So you're good to go. All right? Any question that you have that we didn't answer? Oh, that's good. Thank you so much, Marlene. Exact mechanism of hypocalcemia and acute pancreatitis is unknown. All right, I appreciate you finding that for me. Okay, you guys will do fine on the exam. Relax. Autodigestion and mesenteric fat by pancreatic enzymes. Thank you, Marlene. Excellent. All right. Don't overthink. Everyone will do fine. Everyone will be passing the class. So, hope it's been helpful.